I'm Tony DeMaria, the editor of JACC, here with the highlights of the January 29th issue. A number of studies now have clearly shown that rate control and rhythm control in patients with atrial fibrillation are essentially equivalent in terms of long-term outcome, that is morbidity and mortality. However, there's still a lot of debate regarding whether rate control and rhythm control are different in terms of quality of life and functional capacity, especially in patients with atrial fibrillation and congestive heart failure. So the Canadian investigators who performed the AF-CHF trial specifically looked at this in approximately 1,300 patients. Rate control was fundamentally done with standard AV nodal blocking agents to an exertional heart rate of about 110, and rhythm control with cardioversion and primarily amiodarone. The endpoints were quality of life by a questionnaire and exertional capacity by a 6-minute walk test. Interestingly, in this group of patients with congestive heart failure, there was no significant difference between rhythm control and rate control of atrial fibrillation in these congestive heart failure patients in terms of either quality of life, New York functional class, or ability in terms of the 6-minute walk test. Now, in a sub-analysis, if one looked at the percentage of time spent in normal sinus rhythm as a continuous variable, in fact, there was some evidence that those patients who spent longer than the median in terms of time in normal sinus rhythm did benefit a little bit, suggesting that perhaps if you could maintain normal sinus rhythm continuously in most patients, that might produce a benefit in functional class and quality of life. Nevertheless, as things stand now, based on the best available treatment in this study, there really is no difference between rate and rhythm control, even in atrial fibrillation patients and heart failure. We have a really provocative study in the January 29th issue of JACC relating to the use of colchicine in patients with coronary artery disease. Now, it's been known for some time that inflammation plays an important role in destabilizing plaques, and so it's been hypothesized that treatment with an anti-inflammatory agent could in fact reduce events. Now, to test this hypothesis, the investigators utilized colchicine, 0.5 milligrams of colchicine a day, a drug that's been around for a long time, is reasonably safe, especially in these doses, and has anti-inflammatory effects. And so they took a group of patients with chronic coronary artery disease and randomized them either to colchicine or placebo in a somewhat unusual protocol, and looked for end events which were acute coronary syndromes, strokes, a composite endpoint. What they found, very provocatively, was a significant difference in composite events in those patients who were treated with colchicine rather than placebo. In fact, only about 5% of the patients who received colchicine had an event, whereas 16% of the patients on placebo had events. So a pretty significant difference. And this difference was even greater if, instead of using intention to treat analysis, you analyzed those patients who actually received the colchicine. So a very provocative finding. Can colchicine be a really effective agent in patients with coronary disease? I think we need more data, bigger studies done very, very carefully. However, this clearly and surely does give support to the concept that anti-inflammatory agents may be very valuable in patients with chronic coronary artery disease. The use of the radial artery for cardiac catheterization and even PCI has attracted a lot of attention recently. There's still a fair bit of question, however, regarding the use of the radial artery access in patients with acute myocardial infarction. And to investigate this, a group of investigators went to the NCDR database, so a wealth of data, and looked at just under 300,000 patients undergoing PCI in the setting of acute myocardial infarction. They then analyzed the group of patients in whom radial artery access was utilized versus femoral artery access, and they did propensity analysis to try as best as possible to eliminate confounding variables. And what did they find? They found that, at least in the United States, the number of patients receiving radial artery PCI is still very small, only about 6%. However, there's been a progressive increase over the last several years, and this is likely to continue. Now, what they found was that the procedural success was equivalent whether you use the radial or femoral artery. The door-to balloon time was a little bit longer with the radial artery, but in exchange for that, you had a lower incidence of bleeding, a lower incidence of post-PCI complications. So the net result of this very interesting analysis is that, in fact, even though at the moment PCI by the radial artery approach is not utilized very often, the data available would suggest it's a very effective way to perform PCI in acute MI patients, and that, in fact, bleeding and some post-procedural complications can be reduced. So we've had some provocative and to some degree unexpected findings in the papers in the January 29th issue of JACC. I sure hope you enjoy reading them.